It is my pleasure to welcome you to today's webcast titled Medical Errors in the U.S., the Patient Perspective. Before we begin, I have a few housekeeping remarks. This is being recorded and all audience lines will be in a listen-only mode during the program. The handouts for today's presentation were sent to all attendees in advance of the webcast and will be emailed out again after we conclude. The question and answer session at the end of today's webcast. You're welcome to submit your questions throughout the program. To submit a question, simply type your question in the box titled Q&A and click the send button. If the slides appear to have frozen on your console after we begin today, please try refreshing your browser by clicking the Control and R keys on your keyboard or the F5 button. If you have any additional technical issues during the webcast, please let us know through the Q&A box and we will work to address them. This has been accredited to offer 1 contact hour of continuing education credit for physicians, nurses, pharmacists, risk and quality professionals, and healthcare executives. It also counts towards certified professional and patient safety recertification. All faculty have disclosed in accordance with requirements. To receive continuing education credit, registrants must attend all of today's webcast and register on the IHI website and complete a post-event online evaluation. Details will be shared at the end of today's event and then emailed to all attendees. It is important to note that only registrants attending the live webcast are eligible for credit. Today's webcast will address the following learning objectives. At this time, I will turn things over to our moderator, Matt Kaplan, Communications Director at IHI, to begin today's webcast.
Thank you very much, Catherine, and hello and welcome everyone, and thanks so much for joining us today. Our focus is on medical errors in patient safety in the United States. Largely, we're focusing on what's been experienced and identified by patients themselves, and that's one of the things that we hope you'll find as interesting as we do as well. As you may know, the Institute for Healthcare Improvement, IHI, National Patient Safety Foundation, NPSF, Lucian Leaf Institute, and NORC at the University of Chicago developed and conducted a national survey of more than 2,500 adults. Now, according to findings, respondents generally report seeking medical care on a regular basis and also having positive experiences with the healthcare system. However, as we're about to discuss, some percentage of respondents also report the occurrence of medical errors, which they say had lasting effects on their physical health and emotional well-being. During today's webcast, we will review the survey. In addition, we're excited to share some new research conducted by the Betsy Lehman Center and the Frameworks Institute on the different ways experts, patient, and healthcare professionals think of patient safety. And finally, before opening it up to your questions, we're going to hear from the patient family members and providers' perspectives and how each makes sense of the latest research on medical errors and where we might go from here. So now I'd love to introduce our speakers for today's webcast. Patricia McGavigan is Vice President for Patient Safety Programs here at IHI, and among her many, shall I say many activities, has been closely involved in the work of the NPSF IHI Lucian Leaf Institute. Welcome to you, Patricia. Ed Malone is the Deputy Director of the Betsy Lehman Center for Patient Safety. That's a Massachusetts state agency that coordinates a statewide program of research, data analysis, and communications to reduce medical harm in the Commonwealth. A welcome to you, ME. We also have with us today Steve Littlejohn. He's a longtime patient family representative volunteer at both NPSF and IHI. He currently serves on the Certification Board for Professionals in Patient Safety, the IHI NPSF DAISY Award Panel, the IHI NPSF Patient Safety Advisory Committee, and the IHI NPSF Patient Safety National Steering Committee. Steve Littlejohn is clearly very busy on behalf of patient safety, and a major welcome to you as well. And finally, Dr. Saul Weinhardt is Chief Medical Officer and Senior Vice President of Medical Affairs at Tufts Medical Center and Professor of Medicine, Public and Community Medicine at Tufts University School of Medicine. In addition to his work at Tufts, he has been actively involved with IHI and PSF for several years, and also assisted with the creation and development of the Lucian Leape Institute survey, which Patricia is going to kick us off and tell us more about in just a second. So without further ado, let's turn things over to Patricia McGaffigan, who will give us kind of a good high-level overview of the major findings. And welcome again, Patricia.
Thank you, Catherine and Madge. Madge has nicely introduced that I'll be providing a high-level overview of the results. I would like to mention that the work for this survey was funded by an unrestricted grant from Medtronic, who had no role in the design, analysis, or publication of our findings. The stimulus for this survey coincided with the key publication that we issued in March of 2017. This publication, our call to action, states that patient safety must be regarded as a public health issue, given the unacceptably high and pervasive rates of preventable healthcare harm. The call to action refreshed and reinforced the criticality for stakeholders to address preventable harm in a collaborative and coordinated manner, using a public health framework to guide our response. We decided that it was time for us to really dig into the public's perceptions of healthcare and healthcare harm. We had, in fact, conducted an original survey on this topic 20 years prior in 1997, when the National Patient Safety Foundation was originally founded. So what does the public think? From the end of May to June of 2017, as Madge mentioned, NORC at the University of Chicago conducted online and telephone interviews using landlines and cell phones of over 2,500 individuals through a AmeriSpeak panel participants, which is a nationally representative population of the United States. The survey design included national experts. I've heard a little bit about that in Madge's introduction, as well as patient and family representatives, and also experts who have conducted prior national surveys and opinion polls of the public with respect to healthcare and safety. The sampling error for our work was plus or minus 3.2 percentage points. Participants were provided with the same definition of medical error, which is shown on this slide, and for the sake of time, I won't read it. However, you will have these slides to refer to for the future. As a high-level summary of our findings, the vast majority of participants reported having regular and positive experiences with the healthcare system, as Madge has noted. Those who had not experienced a previous medical error were found to be largely unconcerned about experiencing an error. 6% of respondents felt that patient safety has stayed the same or improved over the last 5 years. Specifically, 39% felt that patient safety had stayed the same, while 29% felt that patient safety had gotten better. As you'll note on this slide, 21% of Americans who participate in this survey said that they have experienced a medical error in their own care. This is noted in the gray and lighter green shades on the circle on this slide. 50% of respondents noted that they knew someone who had experienced an error, which is represented in the green portion of this circle. In total, 41% of respondents either personally experienced an error or someone who had experienced an error, while 15% reported neither. Respondents were provided with a list of 15 types of medical errors and were asked whether any types of error described the situation that they or a close friend or relative had experienced. They're allowed to select as many categories as needed. And on this slide, you'll see that of the 15 types of medical errors, the most common are diagnostic errors. In fact, 59% say the medical problem was not diagnosed, was diagnosed incorrectly, or a diagnosis was delayed. 6% reported that a mistake was made during a test, surgery, or treatment. And 42% say that they received a diagnosis that just didn't make sense to them. Note that the fourth most common error reported was not being treated with respect. This was reported by 39% of respondents. In most cases, those who experienced medical error reported impact on their physical health, emotional health, financial well-being, or relationships with family. 70% of those who experienced an error said that the error had a long-term or permanent impact on at least one of these aspects of their lives. On average, each error had 2 long-term or permanent impacts and 1 short-term impact. 84% of errors impacted physical health, and 73% of errors impacted emotional health. And note on this slide that the permanent or long-term physical or emotional impact of errors are relatively equal in nature. And that's an area that we're really focusing a lot more on, is the emotional impacts of harm. The next slide shows us the breakdown of settings in which the patients reported the errors occurred. The majority of self-reported errors occurred in outpatient settings. As you'll note here, 34% occurred in a doctor's office, clinic, or health center. The same percentage, 34%, occurred in the hospital, but not in the emergency department, while 14% reported that their errors occurred in the emergency department. And the remainder of settings were non-hospital settings, such as surgery centers and rehab centers. Survey respondents were asked whether they reported the error themselves. 45% of respondents stated that they reported the error to medical personnel or other healthcare facility staff. 70% of these reports were made to a doctor, nurse, or other healthcare provider working where the error happened. The major reason for reporting the error was to prevent it from happening to another patient or family member. The most common reasons for not reporting an error were concerns that reporting would not do any good and lack of knowledge on how to report an error. 6% of adults who reported the error say the chief reason why reported was to prevent the error from happening to someone else, and 53% of adults who reported said their major reason for doing so was to help them cope with, fix, or treat problems caused by the error. When respondents were asked who they felt were responsible for preventing medical error, more than 90% reported that doctors, nurses, and other healthcare providers bear responsibility, and 89% reported that hospital leaders and administrators bear the same. Somewhat surprising to many of us, 85% of respondents reported that they themselves have at least some responsibility for ensuring their own safety. And this raises a really interesting question for us all. If patients are in fact open to reporting errors to their provider and sharing the responsibility for safe care, how can we better educate and engage patients to improve safety and raise awareness of how they can report an error if they do have concerns? So my final slide here is just the highlights of the survey itself. The majority of interactions with health systems reported as positive, and most believe that safety has remained the same or improved. 1% report experiencing a medical error in their own care. None of the errors result in harm. However, when harm occurs, it often has a long-term or permanent impact. Diagnostic errors are prominent on the top list of common error types, and disrespect, again, was highly prevalent. More than half of these errors occurred in ambulatory settings, and most believe there's a shared responsibility in preventing medical error. You may download the report and resources on our website, the link on this slide. And now my pleasure to hand off our conversation to Emmy Malone, who is Deputy Director of the Betsy Lehman Center for Patient Safety. Thank you.
To be part of this discussion. We actually conducted a poll in Massachusetts back in 2014 about the public's understanding of and their experience with medical errors, and we got very similar results to the ones that Patricia just presented. I think that got us thinking a lot about the patient safety improvement work that happens and trying to understand better how other people view the work that we do. And that includes patients, families, consumers, and even many frontline healthcare providers. So we set out to try to understand a little bit more about why that is and how we might help people to understand a little bit better. So we'll talk today about work we're doing with Frameworks Institute, the Washington, D.C.-based nonprofit group of social scientists. They use some unique research methods to try to better understand why the experts on a topic of social importance often have a strong understanding of what's wrong and how to begin to fix things, but their thinking doesn't seem to gain much traction more broadly. Frameworks has done some research on issues like addiction, global warming, persistent poverty, and we're really excited to have them working now on patient safety. So what we'd really like to accomplish with this research is to find new ways of talking about patient safety and safety improvement work. Policymakers, patients, families, and the broader medical community to see medical errors as a solvable problem and a problem that needs to be prioritized. I'll present findings today from the first phase, what is really a three-phase project. So for this preliminary phase, Frameworks researchers conducted a series of in-depth interviews with experts in the patient safety field, as well as with frontline providers and members of the general public. So analyzed how the mainstream media talks about patient safety, and I'll tell you more about that later if there's a little extra time at the end. And while there were many gaps in the ways that patient safety experts think and talk about this topic and the way that others do, that you see here stood out as really true challenges when we're communicating about patient safety to wider audiences. First of all, while we all talk about improving the practices, protocols, and systems in place in various healthcare settings, most others think of healthcare in purely human terms, and that they actually, to a large degree, distrust systems. And second is that talk of a safety culture is really as well understood as we'd like it to be. This slide just shows a very quick look at the associations that people have with systems and then with their fellow humans. And when either one is all good or all bad, it's probably safe to say humans win out. Humans are seen as caring, they are natural problem solvers who are perceptive, they can tailor their approach to the particular needs of an individual patient. Systems, on the other hand, are seen as rigid. They can be impersonal and undiscerning. Systems do shine, if you look at the lower left corner of this slide, in people's minds are in their efficiency and their capacity to standardize, as compared with humans who are frequently inefficient and more fallible by comparison. Second difficult challenge is that discussions about a culture of safety take place mostly among those with expertise in the field. Members of the general public, for example, don't see a connection between the safety of their care and workplace norms in their doctor's practices or their preferred hospital. And similarly, frontline healthcare providers don't always see how power asymmetries across the staff and other kinds of institutional cultural norms affect the safety of care. Here are some other obstacles to narrowing the gap between what experts know about safety and how others think about it. And Frameworks outlined a number of cultural models that it's helpful for us to be aware of. And a cultural model in this case is a set of preconceived notions that people have and which they may use to filter conversations about healthcare. It's the frame or the lens that they look through. And it helps us to understand these models if we want to communicate more effectively about patient safety. So, for example, people thinking with the caring doctor model assume if they just find the right doctor, they will be safe. Actually, some healthcare professionals think with this model as well. And the communications challenge that this poses is fairly daunting. It's hard to build constituencies around better policies and practices. Many people believe it all revolves around the individual. A model, to err as human, is familiar to many of us. patients and professionals tend to assume that no matter what, mistakes will be made and harm will occur because people are fallible. And this almost fatalistic attitude is an obvious problem, particularly when we talk about things like trying to reach zero harm goals. Model I'll mention today is also shared by the public and frontline providers. Frank calls it monitor and punish. When people think with this model, they believe the key to a safer healthcare system is just to weed out the bad apples. What I want to talk about is some of the commonalities in thinking about patient safety. The researchers found across all three of the groups they interviewed. That would be the patient safety experts, the healthcare professionals, and members of the public. And these commonalities offer some clues to better communication about patient safety. So in all three groups, there seems to be some general understanding that healthcare professionals bear a heavy load, and that patients can play a stronger role in the safety of their care to improve outcomes, as the research that Patricia presented also told us. Experts and healthcare professionals share some views that are not necessarily held by the public, and those include that adverse events can happen at any time, that fragmented delivery system and lack of robust information sharing contribute to these events, and that systems improvement is needed. And when asked who's responsible for patient safety, expert members of the public, more so than healthcare professionals, some managers and administrators at healthcare facilities are the ones to take charge. So the trick is to learn to talk about patient safety in ways that don't cue the productive models that I spoke of. Instead, need to build on some of these common understandings. For us, that's what's next. Right now, Frameworks researchers are in the field testing some new and potentially useful ways to talk about patient safety that were informed by the research I just outlined. Following that, we'll put together a broader dissemination strategy. And note that this research isn't just for us at the Betsy Lehman Center. All of the insight generated here is intended to be shared with all of you who do patient safety improvement work every day, who advocate for it, and want better tools for talking about the topic. I've already had and appreciate some great input from IHI and PSF as advisors on this project, and really look forward to continuing the collaboration. I'm happy to answer any questions you have a little later in this webcast, but for now, I'm going to hand the conversation over to Steve Littlejohn.
Well, this is Steve Littlejohn. Can you hear me? I've just had a bit of difficulty.
Yeah, line clear. Go ahead, Steve.
Okay. There. Excuse me, I lost my internet there a moment ago. Are you able to hear me now?
Yes, us here in the studio. We can hear you fine.
Okay, thank you very much. My apologies to those of you on the line, but my internet dropped just as I was about to go on, so I was frantically, it came back, and
okay.
I'm very glad to be here.
All right, that's great. Thank you.
Good, okay. What I did is took a look at the results that Patricia reviewed for you earlier, just see what popped out at me from a family member's perspective in the context of patient safety. What really struck me was how we're about halfway there, half and half split. As was mentioned earlier, half reported an error, the other half didn't quite the error. Amongst us that reported an error, big response. Someone spoke openly and directly about the error, about 52%, apologized and took responsibility for the error. That was about 40-some%. Then the get a handle on what the other half where it didn't go according to I'd like it to go in terms of interaction and patient engagement. And so I start off with, I looked at to report, not to report. What I found interesting was that among those that reported, 76% did because they wanted to prevent the error and the harm from happening again. That's quite heartening. It's quite amazing. And for those who say that the report in order to punish, it was way down the list. If you take the side of that, for those, why do some folks didn't report? 50% they figured it wouldn't do any good. Just side of the did report, which said we do good. So the common foundation there, a common belief and understanding. The difference, common belief and understanding is that people wanted to do good and make up and prevent in the future. But what happened was either they didn't know how to do it, and despairing of whether any good. And so what's that? And then you dig a bit deeper, go to relationship and how people are feeling in the context of the situation. And 1% of those harmed, there's a subset of those who felt they were harmed versus the larger group that felt that an error occurred. 51%, half, over half, said not treated with respect. And what was about this respect question was pretty much across most of the divisions that would happen, in the sense that I'm sorry. There were major differences between those among lower socioeconomic, lower health literacy, or those with limited English language and proficiency. The only difference emerged that the folks 18 to 44 felt they were treated with somewhat more direct than folks a bit older. So to concern us in terms of patients and families' feelings, their connection or lack thereof with the care and the systems, as Emma mentioned before, around them. And if we go we were asked, what were the top factors cited as contributing to the error? What Betsy Lehman Center research has done, these human kinds of things, these are all relationship situations, or the flip side relationships, alienation. I felt that people attention to detail, not listening, trained to wrong when there was wrong, these sides of the patient or the family, not enough time for the patient, overstress providers, and lack of communication. These are all human factors in many cases rather than system factors. It helps us understand kind of what the worrying is like for of those who report error, half of those who've experienced error. It is much different than where in a moment ago how the experience went as the way it ought to. Reported apologies, working things better. That almost another half, or feel almost total opposite experience. There's really reason for optimism in the sense that if we can find the right methods of improving that experience of patients and families, that when they're really difficult, particularly after error and after harm, despite that, either in the half where things went as they should have gone or in the half where they didn't go, they all said that they believe that patients themselves and family members have a responsibility for patient safety, and it's right up there with, as I said, doctors, nurses, and hospital leaders, all one team. You can see a major step change in the results on the slide in front of you right now, with health insurance, private health, and government being large, much less. But then in a striking sense, role given by the respondents to the survey to consumer groups and lawyers. I think that is a great foundation, a great starting point, so that we can close that gap between the half where things went reasonably the way they should have gone, and the half where the experience is one that we want to make a lot better. And for now, what I'd like to do is straight down over to Saul for his observations. Saul?
I appreciate the important research that's been conducted to date by the Betsy Lehman Center and by National Patient Safety Foundation. My assignment is to talk about researcher and clinician perspectives, particularly about the findings of the survey that was presented earlier. And I'm drawing on my own experience as both a clinician and a researcher, and hope to sort of frame things in a slightly different and potentially a little bit broader context. One slide that I'll go through, hopefully not in tedious detail, but at least in some detail to give you a flavor for kind of where we're coming from. So let me start at the top. In the survey that you heard about earlier, it was clear that consumers who respond to the survey regard it as a pretty common phenomenon, that personally experienced about 20% of respondents experienced an error in their care, and another 30% described errors in the care of a loved one. That is something that researchers find a little problematic because of the difference between prevalent incidents. The incidence is the number of new events over a limited period of time, and prevalence is sort of a snapshot. And in this particular case, the problem is that the duration of exposure isn't delineated. So a person could have had an event last year or 20 years ago. So it's a little bit confusing. That said, most of the high-quality research suggests that when you draw on both consumer reports or patient reports, as well as information you can draw from the medical record, that the incidence of adverse events, either in ambulatory settings or in the inpatient setting, is at least 1 in 4 patients. So the rates are high, and patients seem to appreciate that the rates are high. There was a very nice study by Joel Weissman a number of years ago of about 16 hospitals in Massachusetts, and another single paper by Tejal Gandhi in the New England Journal looking at ambulatory practices. So there's something that consumers are clearly cued into. From a clinician perspective, these numbers seem high, and docs and nurses and other clinicians I work with wonder about whether these rates, they don't seem to jibe with their own experience, and they wonder how we're characterizing these events, whether they're all harmful events or whether they're something else. So that's just the way that they seem to see the world. Into definition of error, which I think informs this discussion about how common they are, we know from the survey that was just presented that only 50% of patients indicated that they had heard of the concept of the medical error or what it is. In fact, also jibes with what researchers have discovered. They find that researchers often inflate or confuse the concept of harm that a clinician might use with broader concerns about they feel safe in an environment. So, for example, a patient in a room in an emergency department that seems untidy or unkempt or with a blood stain on the floor, they wonder what the heck is going on there. And if the housekeeping folks aren't tending to the floor, then what does that tell about the organization and its culture and the infrastructure they have to ensure that the medications are well tended to, or that the imaging studies are well reviewed. Clinicians, on the other hand, see error as really a loaded term and often are uncomfortable talking about it for reasons I'll get to in a minute. Move to the next row. This concept of diagnostic errors in ambulatory care was very interesting to me. The consumer survey that you heard about just moments ago, patients identified diagnostic delays and diagnostic errors as the most common type of error patients experience. This is really quite different than what we know from the research literature, which focuses more on medication errors, errors involving treatments of various kinds and infections. That said, diagnostic errors and errors in ambulatory settings are an emerging area of research, and a group like the SIDM has drawn a lot of attention to this recently, and it's a growing area of research interest. It's also, for clinicians, an ongoing source of concern from the perspective of medical liability, of practice exposure, and cause a lot of emotional distress on the part of docs worried about it or identified in a suit. Consumers identified complex causation as an important issue, and Steve just talked about this in some detail, that in most error events, patients identified multiple contributing factors, and many of them were factors related to individual clinicians' performance that was suboptimal from their perspective. The idea of multiple causation for events is deeply embedded in the research literature and James Reason's Swiss cheese causation model of error, and it's increasingly an area where clinicians who are less and less practicing in solo practice and more practicing in complex organizations with a lot of hands on the individual patients, where they resonate with that idea that care is complex, that causation is often diffuse and often difficult to, often the result of complexity in the way that services are delivered. The impact of error from the perspective of patients and consumers turned out to be quite long-term, and it affects many types of harm, not only health, but also emotional harm, financial harm, and impact on family relations. This is an area which is increasingly being appreciated by researchers. Thomas at University of Texas, a group Beth Israel Deaconess Medical Center in Boston, for example, and a group in Denmark from the Danish Cancer Society have been focusing on emotional harm as an important source of injury to patient, and one that makes more attention than we've historically given to it. Physicians understand this intrinsically, but in general, practitioners are focused more on the physical injury and how that might be addressed or mitigated. Apology is something that was made about half the time, as Steve just commented on. There's increasingly promising work being developed on disclosure, apology, and offer programs that try to recognize and compensate patients and their families early on after an event. The University of Michigan has been really quite extraordinary in this area and has shown that by identifying events early on, offering an appropriate apology and disclosure, and then trying to keep patients whole results in increased practice liability against kind of all expectations. There's a group in Massachusetts called Macrame, and there's a national effort that AHRQ has sponsored called the Candor Program, which seeks to develop and grow this, and there's some evidence base of its value. Individual clinicians, events are rare, and clinicians are often uncomfortable making disclosures. They're just not practiced at it. They're not sure about what makes a good one. And large healthcare organizations have begun to train up individuals like disclosure coaches who can perish in the moment and help clinicians to understand the best way, the most appropriate way to disclose events. There's still areas of some ambiguity for care providers. For example, harmless errors. Do those need to be disclosed are there certain circumstances where an error without harm would be more distressing to the patient? How do clinicians think about that in a way that gets beyond their own interest in not disclosing and gets to what's really what the patient would want if they had foreknowledge? And finally, the survey talked with some optimism about patients' perceptions about safety, that there is some risk, that systems seem to be getting safer. The research suggests that with respect to certain domains, like infections in particular, with all the work that's been on line infections and urinary catheter infections, that in fact, in certain domains is safer than it's ever been. And with respect to medications, there are a number of interventions that have been put into place over the years around anticoagulants, chemotherapy, IV electrolytes that has rendered adverse events with respect to those drugs much rarer than they used to be. I believe that clinicians believe that care is safer than it has been and that it was in the past because of much of the infrastructure that we put into place. But the thing that they worry about is what's cost? What are the demands that computerized order entry systems in particular and double checking and checklists is imposing on clinicians? And would that be contributing to burnout? And how much is enough? And what are the interventions that actually have the most benefit? And so there is, I think, some concern on the part of clinicians about the shared creation of safety. If many events are now occurring in ambulatory care, how we engage with patients as partners in preventing those events, given patients and families and caregivers have some shared responsibility for dosing meds at home and following up for treatments and so forth. So I think that this idea of getting safer in a world in which care is increasingly provided in ambulatory settings is an area of some significant opportunity. So stop there and turn it back.
Retain, and thank you all for your remarks, Steve, Emmy, and Patricia. And we had already some active things going on with the Q&A. That is how you should ask your questions. Get into the queue using that, and we'll try to get to all your questions. I wonder if you'd indulge me for 2 seconds. Saul, I'd like to ask you this. It seems that Emmy in particular was thinking and talking about research that can hopefully kind of bring about more connectivity and that collaboration by better understanding kind of the mind comes to a lot of these issues if you are strictly on the patient-family side of the equation and or a clinician. And given that we all know that, as I think you kind of addressed in your slide there, in your comments, there can be a lot of pushback from clinicians when things don't seem to be precise and they're too big. The categories could maybe suggest things that just aren't true. So I wonder if you could speak to this idea of where there are opportunities to maybe meet in the middle here somewhere. Because part of what the survey may do in some ways is open up things a little bit more and give patients and families a little more opportunity to, at the very least, to talk about things that have bothered them in the course of their care, even if medical error isn't necessarily always the best category. So wondering how you might even advise colleagues to say, yes, we can absolutely, pick at this and this and that, and pardon the word pick, but I think you made some good points. But what kinds of things maybe might clinicians be open to from this work?
Well, thank you for the question. I think that the idea that emotional harm is an important and meaningful construct, and that patients who experience an error or at least perceived that they had an experience that was the result of an error, that's a real opportunity to build a relationship and to identify vulnerabilities in the system that are either undermining the patient's experience or that may be creating an environment where a mistake could occur. I think physicians and other clinicians will really resonate with that. So I don't see that there's a competition. I think it's really there's some alignment. Organizations like Christiana System in Delaware have embraced this concept that what we traditionally called patient relations is actually a really instrumental part of risk management and patient safety, and that trying to kind of connect those activities is really potentially quite rewarding.
Does anyone else want to comment on that? I invoked you in asking that question to Saul, but I don't know, maybe we can go back up the chain of our speakers. Emmy, any thoughts on that?
Well, I think it's a great question that you ask, Madge. I think that, the work that we were doing was it went on the individual relationship between any patient and doctor. As you saw, there is a real emphasis on human interactions, and I think that the survey work really underscores that. And I think what we're trying to do is take a broader look at how do we talk about what safety is, mostly safety improvement work, in a way that people understand what is it, why is it needed, and who needs to do it. A survey, it's interesting to me the number of people who talked about the patient role, and I would say that we didn't see that quite as deeply in this research, but I think it's a really intriguing, and I think as Patricia mentioned, something that we could all focus a little more attention on.
Steve, something about this.
Not at the moment. I'm listening and.
Okay, that's fine. Just want to give you the opportunity.
Okay, thank you.
Okay, that's great. Thanks for the questions. Cheryl Van Epps kind of started out a little bit in the Q&A scroll with referencing the Joint Commission Speak Up campaign, which has been going on for a while, and in some ways asking, it's a great invitation to speak up, doesn't happen and really as often as it should. And then Cheryl, thank you, goes on and, poses a lot of ideas about why that may be the case. I thought, Cheryl, in addition to your own comments, we'd ask Patricia here some of her thoughts, having been around as these kind of various movements have cropped up. One of the things Cheryl said is also, it's interesting that it's shifted responsibility onto patients around adverse events, which might not have always been fair. Mm-hmm. And one does wonder, as people talk about more co-producing and patients' role in safety, making sure that patients are doing their share of their work that it's fair to ask them to do.
Mm-hmm.
Yeah.
Mm-hmm. I think that's a great comment. And just last week at our National Congress, Dr. Kaveh Shania commented on this when he was reviewing some of the key issues and advancements in safety and quality. The programs that are intended to ideally have patients speak up, I think, are very oftentimes not succeeding for a few reasons. I think they're great in their intent. However, we often put it in the hands of the patients and say, ask these questions, and very often we don't ensure that the entire healthcare team is using the same framework for communicating and also being able to work together with a patient or family member in terms of co-producing safety. So the frustrations that I think we often hear are, and we see this with our own program, the Ask Me 3 program. Someone asked about the Speak Up program, and last week Dr. Shojania said, he mentioned a different program, and he said in all of his years, no one's ever asked him a question about, have you washed your hands? So I think sometimes, we think that these programs, and if they are designed with, the best of interest with professional teams and patient and family advisors and advocates on them, oftentimes don't have the desired effect because we look at them almost as a transactional thing. We put a list on a wall, or we hand a piece of paper to patients and family members, and it's at their most vulnerable times in their lives, and even if they're going for an outpatient visit, that's a very vulnerable time. However, I do think that, with many folks will say, we spend far more time asking questions about buying a car than we about our health. So I do think there is some middle ground there. I recommend that as we think these programs through, and even their own program, we have a trainer program, Ask Me 3 program, that's intended for healthcare professionals, because these one-way ask the questions, or here's a framework for asking important questions about your care, don't necessarily turn into meaningful events if our healthcare professionals are not listening and queuing up with the same types of frameworks in place. But this is where I'd love, Steve and Saul, you may in particular want to jump in with some perspective on that.
Just Steve, I'll jump in momentarily. First, I'd mention that last week at the IHI-MPSF Patient Safety Congress, we had I think a really impressive and fascinating presentation at children's hospitals on engaging families to improve patient safety that had tested programs for reporting and for engagement that showed a great deal of promise. I understand the concern about loading too much on patients and on families. That's always a concern. On the other hand, I would think some number of families go into a situation, say in a hospital or where else, with their loved one, and would doing it to keep an eye out for things, so to speak. And if that's the case, to the extent they can be to do it more effectively, which I think they would desire, we would desire, and also to know that there would be receptivity to reporting and how to do it. I think that would be a plus. You know that when my daughter was in the hospital for close to 9 months out of a year, she was on top of her medications, and if the change in supplier, and that happens, say, with a generic, and it begins to look different, she was on top of that. So she was engaged. I'm saying it's everybody, but I think there's an important role patients and families to play.
Yeah, this is all. I thank you, Steve. That's really thoughtful comments. The Speak Up campaign for a minute. I remember presenting the Speak Up campaign to the Patient Family Advisory Council at Dana-Farber Cancer Institute, where I was working at the time, and one of the representatives said to me, the Speak Up campaign is fine, but really you're asking the wrong question. The wrong question is, should we participate and speak up? The right question is, how do we create a menu of opportunities for patients and families and caregivers to participate in promoting patient safety, recognizing that, number one, their willingness and ability may vary across patients, but also may vary in particular patients across time and an illness. And how do we do that without shifting burden or responsibility for safe care to them? So this idea of the menu, the opportunity, seemed really key. The other thing that I wanted to just echo a comment that I see that Cheryl has posted is about this concept of shared decision-making, which is so important when it comes to diagnostic errors. The Institute of Medicine report on diagnostic errors pointed out this really important insight, which is that if we don't deliver care to patients that's consistent with their goals and values, then we've really missed the boat and, in fact, caused a harm that is avoidable if we deliver care that is consistent with goals and values, then we're avoiding a diagnostic or treatment error.
Thanks for the comments on that issue. I wanted to acknowledge Lynn. That's a question asking whether there was any data gathered regarding communication and resolution programs and what patients have to say about disclosure and that kind of thing. That is not in this particular survey. I don't know if that's been gathered for any other survey. Feel free to weigh in maybe on the Q&A if that's true. But thank you for that question. I wanted to ask whether or not there is a sense there with patients among the findings. I'm not looking at my chart, but I know that I thought it was interesting in the survey that there were times when patients did register that results just did not seem right. Able to speak up if something just did not sound right or feel right. And I wanted to ask you, Emmy, whether that's, again, kind of almost one of those human things where somebody is telling you something about yourself, which, you know, you don't know maybe what all the lab results say and this and that, but something is just not adding up to you. And if that kind of, you know, ends up being emblematic of some of what you're also talking about in terms of the work at the Lehman Center.
Yes, and I think that this is all rolled together. I mean, among the models that the Frameworks Institute identified when talking with patients about medical harmful error that I didn't specifically speak to today was one around the idea of the the doctor knows best model, and people do tend to talk about healthcare professionals through the use of the word doctor. So when I say doctor, it's not necessarily just the doctor. The idea that they know best, and that there still remains a factor in many patients' minds that someone else knows more than they do. And I think if you add on top of that, and I'm speaking really just for myself, when I'm a patient and you're under some stress, you're in an unfamiliar environment, you're sitting there in that silly little paper Johnny, you don't necessarily feel as empowered as would be ideal in those circumstances. And but I do think that, you know, going back to some of what we saw in this research and to the survey that the Leap Institute did, I think the idea that patients do see a role for themselves and for their families, I think is really positive turn compared to, say, 10 years ago.
Okay, very much. Thank you, Emmy. We're rolling to the top of the hour right now, and I guess I just wanted to acknowledge one more question here, if that's okay. Julia has wondered about electronic health records and whether the electronic health record was considered in the survey in terms of patient safety. I think I'm safe in saying that it was not, but remind me, Patricia, because I may have forgotten about something.
I know. I believe that's absolutely correct.
Yes.
I did note that patients could not see their own medical records.
Yes.
So that did come up as one of the factors that patients used when they identified a contributing factor for an error. And lack of attention to detail was high on the list, and that was noted earlier on in the chat box. And you know, beyond this, you know, vague patients couldn't see their records, we did not delve into that area. There's some very interesting work going on, of course, with patient portals, and you know, there have been some benefits shared just in terms of basic history, physicals, and findings and follow-ups. However, in the realm of medical error, I do not know of any research. Saul may have some insight into that he could use to close down that question.
Okay. Saul, you want to
Sure. I mean, there's some promising work that's been done about the use of patient portals to report adverse events or other safety concerns. I think the jury's still out on how good that data is, and I think we need better methods for doing it. There's certainly been work that's been done more along the lines of, Yelp and rating providers and engaging consumers. But the portal-based ones offer, I think, a more potentially more scientific source of information. I think there's a lot of potential there, but I think there's still a bit out on the best way to do that.
Thank you very much, Saul. Okay, so we have reached the end of our time today, and I did hear several issues that would make for some good discussion going forward related to the electronic health record, also more perspective from patients and families on these resolution and disclosure programs, and numerous other things. I think this whole area of disrespect is a really interesting area as well. And I just wanted to also, as kind of an aside, because they let me in front of the microphone here, for my another program that I do, we just started learning about programs both in the UK, well, in the UK mostly, that are teaching patients and families QI and quality improvement and improvement methodology as one means of bridging gaps around understanding, getting back to some of what the Lehman Institute is looking at in terms of a way of beginning to sort of get everybody speaking about systems. I think obviously the learning has to go both ways, but that's kind of an interesting development too. All right, well, big thank you to everyone who joined today and our speakers, and that includes Patricia McGaffigan, Emmy Malone, Steve Littlejohn, and Saul Weingart. You see on the screen, these are the instructions for receiving continuing education credit. Please note that these instructions will also be emailed to all attendees following the conclusion of this webcast. And again, it's been an honor to moderate today. My apologies for my cold, and that will get better too, along with everything else we're looking at today. Again, thank you, our audience speakers. This concludes today's webcast.